Hi everyone, my name is Jessica Cothran. Thanks for joining me here on this Friday. I wanted to kind of present this today. You've shown up for child and adolescent suicide assessment and prevention. Of course, my name is Jessica Cothran. I'm an LCSW. A little bit just about myself. I've been working with kids and teens in mental health for over 12, 13 years now, and working with assessing for suicide. I work here at Laureate in the children and adolescent unit, and have been here for over the last year. Prior, I've worked in community mental health for over 11 years, working with teens across the school districts. I worked as a therapist and supervisor. Had also responded to crises. Anytime you hear about what's called psychological first aid, crises in the community, that could be a suicide at a school or a tragedy. That was something that I had also responded to. So what we're going to learn today in this training is in behavioral health and medical settings, being able to use the most comprehensive assessment tools for children and adolescent suicide screening and safety planning. How to inform clinical pathways to identify suicidal factors and assess for suicide. And finally, how to identify and collectively construct a safety plan and use appropriate follow-up evidence-based treatments. So, as you may know, suicide is a major public health crisis. But today we're going to really talk and focus on finding hope because suicide is preventable and treatable. So it's great. Having hope brings hope. So this is the one thing that I want to instill in this presentation. This can be sometimes daunting when talking to families and individuals and even promoting community awareness. But remember, having hope brings hope. So remember, we serve as hope makers. We are dream makers in a lot of ways to our families and individuals and the kids that we serve. We are life fosterers. So through this presentation, some of the things that we're going to focus on and learn is reducing stigma as mental health professionals, creating safe and supportive environments, and promote health-seeking behaviors. We're going to train to recognize warning signs and respond to those warning signs in a fast and appropriate timing. So we're going to reduce, create, promote, train, and respond. So one of the common things that I want to bring to the table is all across the board having a common language among professionals to address and define what suicide is. As we know, with our continuing education, sometimes the terms that we use progress and change over time. So we're going to look at some of those. So suicide is defined as death caused by self-directed injurious behavior with the intent to die as a result of that behavior. So a suicide attempt is a non-fatal, self-directed, potentially injurious behavior with the intent to die as a result of that behavior. So in looking at that, there are two different things. That suicide attempt could be interrupted as the reason why somebody didn't die of suicide by either some unforeseen circumstances, parents coming home early, all kinds of different things, or it can be an aborted attempt. The person either self-stops themselves and interrupts the attempt too. So in looking at some of the other definitions, there's preparatory acts and behaviors is acts of preparation towards immediately taking and making a suicide attempt. So this is a little bit different. It's beyond verbalizing the thoughts, such as assembling specific methods. Some examples are like buying pills or purchasing a gun, even sometimes giving away possessions, preparing for one's death, writing a suicide note, either by written or even social media, sometimes posting different comments about saying goodbye to people. So again, when looking at a suicide ideations, refers to thinking about or considering or planning suicide, that wish to be dead. So it can look some different ways. There's non-specific, and defined as non-specific active suicidal thoughts are, I wish I wasn't here, or nothing matters. Then there's the active suicidal thoughts with method. That's the, collecting the pills, or could be getting a rope or getting a gun without the intent to act. So having a thought of how they might kill themselves, but no intent to act on it. And then there's active suicidal ideation with intent to act without specific plan. So they want to act, they want to kill themselves, but not knowing exactly how they might want to do it. And then active suicidal ideation with a specific plan. So not only have I obtained pills that I want to take, but then also when I'm going to do it, how I'm going to do it, and the intent to act on it. We also have non-suicidal self-injurious behavior, or also NSIB, is any self-inflicted destructive act performed with or without the intent to die. Full intent is inflicting physical harm to oneself. So in the terms that we're not going to be using, talking about like defining those terms and having common language, is suicide gesture. This is something that is not recommended to be said by the National Institute of Mental Health. So kind of defining and going further, we want to address some epidemiology about the suicide in children and adolescents. So this comes from the American Association of Suicidology. So suicide is ranked 10th in the leading cause of death in the United States currently. So these are some really hard statistics to kind of hear. So average one person every 11.1 seconds kills themselves, and one male every 14 minutes, and one female every 51 minutes. So suicides ranked second in the leading cause of death for adolescents and young adults, and ranked third in the leading cause of death among children. So average one person ages 15 to 25 dies every hour and 28 minutes. So if we add the younger populations of 15 and younger, adding those 546 suicides, it averages to be one child or adolescent dies every hour in 20 minutes. So Oklahoma is ranked 8th in the nation on suicide deaths per year. So this slide just kind of reflects those statistics and kind of brings it to the point, like I said, those ages 5 to 14, ranking suicide as the third leading cause of death, and those ages 15 to 24 ranking second. As you can see, those even numbers and those total numbers of deaths for 2019 statistics was children under the age of between ages of 5 and 14 was 843, and adolescents to young adults, those numbers for 2014 or 2019 was 6,211. So as a nation, the total number of deaths was 47,511 for 2019. That's 130 deaths per day. Males, of course, were higher. Females, and where whites versus non-whites, African Americans, and where our youth fall. And this was from the American Association of Suicidality. So according to the CDC and the National Institute of Mental Health, suicide rates have increased by 33% since 1999, which is a pretty significant amount. So one of the things that we're going to be doing in this presentation today is how can we decrease that rate over time? So more than 47,000 lives are lost just in 2019 alone, like we've already even stated, and the financial toll. So looking at the financial toll of suicide attempts, the cost is over $7 billion. So how can we spend that money in other type of intervention programs? Because this is the money that's spent over the lifetime of medical dealing with the toll of suicide and suicide attempts. So we know that this is a huge issue. So one of the things that it affects is in how we're exposed to it. So many people are exposed to suicide. So we look at exposure and even suicide survivor loss. So it's anybody that's been affected are those that have been affected personally who have died by suicide. So research suggests that for each death results in 147 people are exposed. And an overwhelming amount, that's 6 million per annual year. So between 40% to 50% of the population is exposed throughout their lifetime to suicide. So a study from the CDC of suicidal ideation and behaviors among high school students survey showed that 18% of students nationwide reported seriously considering attempting suicide, among females being higher at that 24.1% and males being 13.3%. 15.7% of students had made a plan about how they might or they would attempt suicide. Of course, again, the statistics being higher for females than for males, and 8.9% of students had an attempted suicide at least one time, being higher among females again than males. And 2.5% of students had made a suicide attempt requiring medical treatment. So, and also looking at various populations seriously considering or attempting suicide, looking at sexual identity overall, heterosexuals being 14.5%, or those teens identifying as heterosexual, the lesbian, gay, and bisexual. They didn't include the transgender or questioning group. The questioning group we're not sure was the 30.4%. So you can see which percentage by identifying sexuality overall being the highest and at greater risk. Because my presentation has been shortened to 1 hour, I really like to sometimes even talk about other at-risk populations, being the Native American population, and also talking about adopted or children in foster, teens in foster care. And I can include those statistics for you in an email, but because of time, those things have been shortened. So some other epidemiology of suicides for children and adolescents. We know that rates of attempted and completed suicide increase dramatically with the age throughout childhood and into adolescence due to the elevated risk of psychopathology and that occurs during adolescence. The increased capacity to prepare and execute a suicide plan with cognitive maturity is also one of the reasons why that risk greatly increases with age. Decreased supervision with age and parents allowing them more dependence and staying home by themselves definitely increases throughout their age. Prepubertal children do endorse suicidal ideations, but their cognitive maturity appears to be limited ability to plan or execute lethal suicide attempts. And then, of course, the population of our younger kids, 5 and below, suicide behavior is commonly rare, not uncommon, but can be very rare. Most common, it's present when there's physical or sexual abuse. So assessing for traumas can be appropriate with that demographic too. So how to incorporate suicide screenings and safety assessment. So zero suicide and, encouraging to being a zero suicide organization is one of the things that can be very helpful. Zero suicide says to assess every patient. So in February 2016, the Joint Commission, according to organizations of health care programs and hospitals throughout the United States, issued a Centennial Event Alert recommending that all medical patients in all medical settings, inpatient hospital units, outpatient practices, emergency departments be screened for suicide risk using valid suicide risk screening tools that have been tested in the medical settings and with youth. Will help clinicians accurately detect who is at risk and who needs further intervention. So looking at that, one of those things in detection is also looking for those warning signs. So thoughts and feelings of feeling like there's not a reason to live, talking about feelings of hopelessness and having no purpose, feelings of being a burden to others, too little or too much sleep, mood changes or mood swings, having excessive negative thoughts. They feel that they cannot stop, no future orientation. So behaviors, too little sleep or too much sleep, isolating or withdrawing, acting anxious, agitated or restless, using drugs or alcohol for teens and adolescents, talking about wanting to die, looking for a way to kill oneself, collecting pills, obtaining a gun or talking about obtaining a gun, giving away possessions, saying their goodbyes by suicide note, verbal comments, in person, notes, texts, letters, and on social media. So in looking at children and adolescents, those risk factors are continuous hopelessness, lack of social support or a sense of feeling completely isolated, being a victim of bullying or cyberbullying. As we know, social media plays a huge part in many children and adolescents' lives currently, all of our lives. Impulsive or aggressive tendencies, being exposed to trauma or abuse, having a major physical illness, comorbid psychiatric disorders, unwillingness to seek help because of stigma related to mental health, substance abuse disorders, or suicidal thoughts. Culture or religious beliefs can play a big key, such as the belief that suicide is a noble resolution to a personal dilemma. Loss of relationships, any perceived recent losses of it could be sports or sports injury or anything, loss of a scholarship that they had their heart set on. It could be lots of different, any type of perceived loss, perceived or discrimination, easy lethal means, previous attempts, exposure to others who have had died by suicide in real life or even on the media or internet. Family history of suicide, and then there's also suicide clusters, and those are suicides that happen in a community, in a school, but multiple suicides within in a select amount of time. So with all that, one of the things I want to really focus on and instill in this presentation and for you to take away with is that it is everyone's responsibility for suicide prevention. It's not just mental health, it's not just doctors, it's not just nurses, it is everyone's, teachers, parents, coach, everybody's responsibility. So everyone is touched by suicide, either on a community level, an interpersonal level, or even sometimes a family level. So suicide risk screening in pediatric hospitals and clinical pathways to address a global health crisis. Why is this important? Because medical settings are uniquely positioned for youth suicide prevention efforts. So in our statistics, 80% of youth visited a healthcare provider prior to death. So youth come in, they're most commonly come in for their well child checks, sports checks, sports injuries, all kinds of different things, school illnesses. So this is a thing that most kids are being able to present in some type of a medical or healthcare with face-to-face with the provider. So having this type of assessing for suicide to see if the child or adolescent is risk is very important. So 40% of youth visited a medical setting within 1 month of killing themselves, and more than 1,000 deaths from the time of 2010 to 2014 following a 72 hours of being discharged from an inpatient or medical emergency departments. So one of the things that was set in motion is that the Joint Commission requires suicide risk screening for all behavioral health patients presenting in psychiatric general hospitals. But then even more, they went a little bit further. In 2016, the Joint Commission broadened that recommendations to all patients in medical hospitals, including behavioral health complaints, be screened for suicide using valid tools. So kind of like what I just said, we're all touched in our community. This hits really close to home. I brought this into the, just even seeing that May 3rd of this year, within this month, that this is young Nate, age 15, lives in Edmond, and died by suicide. As a community, not just like I said, mental health providers, but everybody recognizing the warning signs as mental health providers, as teaching our parents, and parents being able to broaden that education to anybody that touches a kid. So as a community, we need to do better in mental health to really advocate and get the word out about suicide, that it is something that is preventable and how much it does impact our children and our youth. So as you can see, this was Nate who wrote and expressed thoughts of suicide in an essay at school, and these concerns were not addressed, and it resulted in him reaching out possibly for support, not being heard and ignored. So this is one of the things that we're going to do, is we're going to bring hope, we're going to educate and give tools. So what can you do if you think somebody is at risk for suicide? So we can reduce the stigma by using psychoeducation and normalizing the effects of what depression and mental illness and how many people are impacted, and being able to talk more about open discussions and asking people if they are suicidal with our children and our adolescents. Create safe, supportive environments using strength-based, client-centered, and family-centered approaches. Promote helpful seeking behaviors with hopefulness and resiliency, and train to recognize warning signs and train caregivers and other supports to recognize warning signs. So responding to warning signs with early intervention is a key tool. So in reducing stigma by using psychoeducation, first off, the saying you are not alone. So kids, teens, and adults often feel alone when having suicidal thoughts. Really, education through depression makes everyone feel alone. And what can bring depression? Sadness, loss, bullying, injustice, discrimination, traumatic events, cyberbullying, and so much more. Really start with a stance of, let me understand your experience. Unite side by side with a child and adolescent. Just them feeling heard can be the biggest tool. Reducing stigma by psychoeducation, don't be afraid to ask directly. Say, are you having thoughts of hurting or killing yourself? So the myth is that asking about suicide can put the idea in their head, but asking about suicide will not put the idea in their head. So in fact, a lot of people thinking of suicide feel revealed when they can talk about their feelings, relieved. Create safe and supportive environments by using strength-based, client-centered approaches. So listen to them like a true friend. Someone thinking about suicide needs your support. So don't say they're being silly, dramatic, or overreacting. Don't interrupt or try to say things that are not as bad as they think. So just let them talk about their feelings and be a good listener is what I talk to families and those adults around them, to just kind of listen and be that child's advocate and join with them to know that they're not alone. So tell them that you're worried or concerned about them. It can be a big thing in selling. It seems like you're sad lately, and that worries me. Or also, what you said about wanting to hurt yourself really concerns me. So let them know that they have been hurt. Don't be afraid to repeat back what you've heard to make sure that you understand. It sounds like you have been really sad and angry over these arguments with your girlfriend. Don't judge and say, just let them know that you are listening and that you understand why they're upset. So promote help-seeking behaviors with hopefulness and resiliency. So other people have felt this way before, overwhelmed, depressed, scared, angry. Even more importantly, let them know that you and others care and that you're there to support them. So they may feel like no one can help. Like I said, that feeling of feeling completely alone. They may be out of better options for escaping their feelings or situations that feel unbearable or painful. But feeling better again someday can be possible is the thing that we need to instill. Other people, letting them know other people felt this way and have recovered. So train to recognize warning signs and train caregivers and other supports to recognize warning signs. Have them identify trusted adults in their life that can also look for these warning signs, like a parent, a sibling, a teacher, a coach, a pastor, and many more. Whoever touches this child or has contact on a daily basis with them can recognize warning signs. And being able to talk to them that, hey, I'm kind of, let the parents know, talk to other people, hey, I'm kind of concerned about my kid. Can you kind of watch and let me know if you notice anything that's up or something that might be different with them? More eyes can save lives. So don't ever keep, and let them know, don't ever let and keep suicidal thoughts or plans secret. tell them that just talking about them can really help. So respond to warning signs with early interventions. So one of the early interventions, CPR. We all know about CPR. We train, it saves a life. Well, there's something called QPR. Both are part of system design to increase the chances of survival in the event of a crisis. So QPR is question, persuade, and refer. So question, making those direct questions. Are you thinking about killing yourself? Persuade is, persuading them and talking to them about getting help, and then referring them, anybody in their life, like I said, those coaches and those other eyes, referring them to a healthcare professional, referring them to call 911 and seek emergency help if needed. So the sooner the warning signs are detected and help sought, the better the outcome of suicidal crisis will be. So getting into assessment. So the next step is really, as professionals, how do we assess? There's a couple of tools that can be used that I'm going to be talking about today, and I have also attached in the links that will be sent out at the end of my presentation. This is the Ask Suicide Question Screen. Ask Suicide Screening Questions tool. It's a brief, validated tool for use among youth and even adults, and it's also endorsed by the National Institute of Mental Health. It only takes 20 seconds. It's approved by the Joint Commission for all ages, patients 8 and older, to screen for suicide. As there are no tools for the use of kids under the age of 8, it's more recommended if there's suicide risk or suspected in younger children to do a full mental health evaluation. And the resource is absolutely free. The initial screening can be done by those that are not in the mental health. It can be done by lots of different individuals and different professions. So you don't have to be a trained mental health professional to ask these questions. Like I said, if you answer to the top 4 no, then you don't even ask the 5th question. So it's pretty simple, it's pretty laid out, even lets you know the steps, and always provide resources to all patients on how to, those professional resources to seek help with the National Suicide Prevention Hotline. So it's kind of really easy. So in the past few weeks, have you wished that you were dead? And just answer yes or no. Like I said, in the past few weeks, have you felt that your family would be better off if you were dead? In the past few weeks, have you been having thoughts of killing yourself? Have you ever tried to kill yourself? And then if they answer yes to any of those above, then you would ask the 5th question, are you having thoughts of killing yourself right now? So that's a tool that can be used in lots of different settings. This one is only recommended. This is done by our behavioral health clinicians and MDs, CNs, and physician's assistants. This one takes about 10 to 15 minutes. It's the brief suicide safety assessment. I really like this one. You can, each time that you're asking them, always praise. It starts with like praise the patient for talking about their thoughts. Assess the patient, like frequency of thoughts. Goes into suicide plan, past behaviors, looking at and checking through symptoms. Also looking at their social supports and their stressors. So we also like to talk about protective factors versus risk factors. And what protective factors does this patient have that can keep them safe or keep them safe in the environment that they're currently in? So a lot of times it is assessing is a less restrictive care or level appropriate than a more restrictive care. And like I said, this one is a 4-page assessment, takes about 15 minutes. You interview the patient and the guardian together, and then you also make a safety plan with the patient and include the parent in that too. So, and then determine with that, what level of intervention needs to happen. So does it need to result in emergency psychiatric evaluation, an inpatient evaluation? Does there need to be further evaluation? Can it be something that's maintained on an outpatient basis and that the safety plan can suffice? And follow-up. So talking about clinical pathways for us, this kind of outlines what to do even using the assessment versus low risk. They answer no to any of the questions, then it's a negative screening. If they answer yes, then does it fall into the low risk, the further evaluation needed, or the immediate risk? So this is nice because you're able to, no matter what, with whatever screening tool, you still have your clinical judgment that you need to refer to, but it is something that can be very helpful. So another assessment that I want to kind of address is the Columbia Suicide Severity Rating Scale, or the CSSRS. It's a questionnaire used for suicide assessment developed by multiple institutions, including Columbia University and the National Support with the National Institute of Mental Health. So it's multiple evidence supported. It's accessible and across many different countries and many different cultures, so it's culturally competent. So the Columbia Protocol is suitable for all ages, and there's some adaptations for pediatric and the intellectually disabled. Part of a national and international public initiative for assessment for suicidality. It's simple. So ask all the questions in a few minutes, or with no mental health training required to ask them. So there's accessibility. Like I said, it's available in 140 country-specific languages. So the initial screening can be done by non-clinical staff and successfully implemented across many settings. So I am including the link in this too, they have assessments for college campuses and schools and military, fire departments, the justice system, pediatric primary. There's lots. There's even a Columbia Suicide Severity Rating Scale combined with the SAFE-T. So those two assessment scales are even combined to look at. What's really helpful is looking at assessing through the lifetime, recent events, and since the last session. So it's endorsed, recommended, and been adopted by SAMHSA and the National Institute of Mental Health, and many others. And it's absolutely free and available online. So this is the screening tool that can be done by about anyone. At the very end also, there's a peer-to-peer support one for teens that you can. There's an app, by the way. You can download this Columbia Suicide Severity Rating Scale app that can be very useful. So it kind of does this tiered, easy, even color-coded one that I've included in the presentation. And it takes the guesswork out of it, meaning that it has very clear language, there's no ambiguity, so it asks the questions very directly. And, just in a quick moment, if, doing just a few questions to the whole thing, have you ever wished that you were dead and could not wake up? Yes or no. Have you ever actually had any thoughts of killing yourself? If they said no, I've never had any thoughts of killing myself, then you don't really have to ask the other questions. If yes to the first two, then you ask the 3, 4, 5, and 6. So just to kind of go over the more in-depth assessment that's used for the mental health professionals, it kind of, this version is the risk assessment version. It's a little bit longer. And again, I've attached the links at the end of the presentation that can be available for you. This one that I've attached doesn't have the safety to it. It only goes over the lifetime and the most and over the last month. So asking them which one is most severe, if how their feeling of suicide was more severe over their lifetime, say like a year ago they were most severe, compared to today, there may or may not be as severe. And again, just kind of continued. This one actually goes into actual attempt, interrupted attempt, and asking about the specifics, the aborted or self-interrupted attempt, and even going into asking about preparatory acts. I've included this because I think it's very great because this is the peer-to-peer Columbia. They can ask for each other. Like I said, there's an app for this. So now safety planning. We've assessed what the risk is, and we're looking at, regardless, safety planning is something that can be very, very helpful in any type of mental health situation, but really talking about when somebody is to the point of having suicidal thoughts and what to do. So safety planning can bring hope. It increases a person's self-efficacy and self-confidence. It helps plan ahead, helps to reduce impulsivity, and helps manage someone's risk over time. So like I said, it can be a lifesaver. So who needs a safety plan? So it's building a conversation on safety starts with that initial appointment when working with children and adolescents and their parents and caregivers. Set the groundwork at the absolute beginning with discussing suicidality and ensuring the basic safety needs to be set. Everything from bad day planning or things that I do, what to do in a bad day, to having a coping skill plan, to even more having a safety plan. But with all of that, no matter what, always providing to every patient, every client, every parent, the National Suicide Prevention Hotline and resources and local resources, because you never know who in their life could be affected. So collaborate with parents and guardians and have them enlist the help of other caregivers and supports to that child and adolescent. Those who had current or past suicidal thoughts, homicidal ideations, and self-harming behaviors are who needs the safety plan. So safety plans, there's two different types. So say safety plan can be managed. So safety can be managed. For adolescents and children having those suicidal thoughts and assessing the severity of the ideation, if that clinical opinion and that parent and that child adolescent feel that they are able to manage that safety with 24-hour supervision, and you find that the risk is more in the low or low moderate, then you can, using that safety plan in place to ensure that safety. When referring for hospitalization, regardless when somebody is with you, making sure no matter what chain of action that you're doing, that you still have a safety plan always in place. So parents, they don't feel that they can keep their child or adolescent safe at home, or the child or adolescent is highly resistive or even uncooperating to ensure safety. So like I said, always even create that safety plan with the parent, even if you don't have any support, even if you don't have any participation with that child, because you want to make sure that that child is supported no matter what. So how to construct a safety plan. So some basics that I've kind of added to this that I should be included in all safety plans are helping them in identifying triggers. So what are your common triggers? And asking them about that and having them write those things down or having them identify them so that they can have them. So what are the warning signs? What thoughts, images, moods, situations, behaviors indicate that you're in crisis or a crisis might be developing? How do you know when things are getting out of control and you need help? So identifying those coping skills is what are some of the things that you can do on your own to help you not act on urges? Which coping skills have been most useful in a crisis to you? So those already kind of natural coping skills that I already use and go to. Reasons for living. So what are some of those protective factors? What are some of those things that are important to you or worth living? What supports and contacts? So who can you call when feeling upset? Creating a support network for that child or adolescent. It could involve the parent or guardian, or it can involve maybe other supports. Places for distraction. What are some healthy social settings that can help you take your mind off things? Restricting means is also something that should be included in all safety planning. If there's any means involved, or restricting, talking about the environment and how to make the environment safe for the child and adolescent. So discuss with the parent about the removal or restricting access to lethal weapons, harmful materials such as guns, knives, razors, medication, prescriptions over the counter, alcohol, hazardous chemicals, ropes, or anything else identified. So, and then always giving crisis professional contacts. So it can include many things like the psychiatrist, therapist, PCP, 911, and then national and local hotlines. So some action steps with safety planning. So safety planning needs to be a collaborative effort with the child and adolescent feeling in control. It's very important that they feel absolutely in control every step of the way. So, and this hopefulness, resiliency, saying, you got this kind of attitude, which instills hope in all that who's involved in the child's care. So the client needs to be client-centered and client-driven to speak to them wanting to use their safety plan, and help parents and caregivers enlist other supports such as teachers, school staff, coaches, neighbors. Like I said, all eyes are important. It takes a village, as we say, to raise kids, and sometimes it takes a village to make sure that kids and adolescents can ensure safety too. And having them being aware of asking for help is the one main thing that can help promote prevention in suicidality. Review and update the safety plan at appointments. So safety plans can be fluid. They're always changing and adding to them, taking them away, what works, what doesn't work. So rehearse the safety plan. So we rehearse fire drills. Why not rehearse the safety plan? It's important. We'll know what to do. We'll feel in control. We'll feel some way of feeling safer to help the child make sure that they feel safe. So foster confidence in using that safety plan and practicing that safety plan, even if it's one used on a bad day. Teaching children and adolescents when they need to cue or access their safety plan, and teaching parents and caregivers with their children when the risk has increased and it is an emergency, and when to seek immediate emergency care can be absolutely important. So at what point do they need to call 911? At what point do they need to go to an ER or go to a psychiatric hospital for an evaluation? So talking to them ahead of time on what that looks like and what instills an emergency. and how they know that their child's risk is at most the most important at this point. Discuss barriers and how to problem solve and revise a safety plan. Like I said, it's always changing. So safety planning. So 17% of U.S. High school students report that they have seriously considered attempting suicide in the past year. So let's talk about this digital connected world that we have. And research shows that 92% of teens go online daily, and 72% report that they spend time with friends on social media. So it's become critically important to devise suicide prevention tools and resources that can reach youth where they socialize, which is online, like many of us. So here's 2 tools that I've included that I use most when I'm working with teens and adolescents and even adults when doing safety planning. There's 2 apps that you can download on your phone, encourage and share, have them share them with their family, talk about them. There's suicide safety planning. I really like this one a lot. It does walk through a lot of the different warning signs. It walks through each thing and has them put it in their phone. Then there's also Calm Safety Plan. It is also a really good one to use. Sometimes even just starting that safety plan can be on paper until they can put it in their phone. And like I said, this just has all the basic things we talked about that are needed for a safety plan. I've attached links to the end of the presentation, so you can also have this one. Other mobile crisis supports are teens like to text, so they can text to 747 for the National Lifeline Prevention Lifeline, and it's 24/7. I've also, COPES is a local provider for the National Suicide Prevention Hotline and including their number. 2 also apps that I talked about was the Columbia Protocol app that you can use yourself or also give to teens and their families, and the virtual Hope Box. So treatment. What we know for treatment, ethically supported treatments are cognitive behavioral therapy, looking at being able to look at those thoughts and being able to challenge thoughts, being able to use and access coping skills, the suicide prevention and brief therapy with CBT. Another one by Dr. Job is the collaborative assessment and management of suicidality. This one you get trained in and have consultations for. I'm trained in CAMS in management of suicidality. Dialectal behavioral therapy, DBT, is another one that has been ethically evidence supported, and medications that are aimed at symptom reduction for SSRIs for depression. So those are the ones that are the go-to for treating suicidality, managing those symptoms. So let's talk about yourself. So all of us being in mental health can be really long. Working with those that have been in mental health and at a crisis level can take a toll on any of us. So I wanted to give some resources and supports for that. On a plane, what do pilots tell us in a crisis? To assist ourselves with oxygen, and then to assist the people around us. We're not taking care of ourselves, so we can't take care of those around us in crisis. So secondary traumatic stress and compassion fatigue are real things. One of the things with the National Childhood Trauma Stress Network, their secondary stress, the fact sheet for those professions serving children, a resource to kind of use and rate yourself on and see where you are is the Professional Quality of Life measure. I commonly use, like I talked about, the psychological first aid, And in there, it even has an assessment for providers to see where you are on compassion fatigue, or can you respond to different crises. And then I've also put in here a mobile resource for mental health professionals, the We Care Empowered. So attached is some resources that you can use. I really do thank everyone for joining me today. And I would love to do a even bigger presentation. I feel like an hour is really hard to go over all the resources and everything else that can be very helpful. I hope everybody has a wonderful day.